Well, good afternoon, ladies and gentlemen, and a warm welcome from a beautiful day in Cape Town. My name is Peter de Jong, and my co-presenter, Professor Stephen Jeffrey, is away in Barcelona at the IUGA meeting. So he's asked to send his apologies, and we do give him his excuses. So it's a great pleasure for me to have this afternoon Professor Trudy Smith. She's a person that's been on our webinars very often before, and it's absolutely a great privilege to have her with us. Her talk is the evolution of the pill. And for those of you that don't know, there is a new pill, and she's going to tell us all about it and how pills have evolved through the years. Just before we start, I'd also like to warn you that FIGO is fast approaching. The FIGO meeting is in Cape Town this year. It's in October. It's in October at the CTICC. Now, Trudy tells me it's expensive, which is true, but as the organizer, luckily, I'm not sure how much it costs. I get a free entry, but, and this is a big but, if you get a few of your friends together, you get a vicious discount, up to 25% discount if you get a group of your colleagues together, and you can register as a group. You put your group forward, they register you and give you quite a big discount. So without further waste of time, Chris, and thank you for Chris for being with us this afternoon. Chris is our webinar grandmaster, and he's going to be assisting with the presentation. We've already got some questions come through, so I'll keep them. And I'm sure Trudy, who's an old friend of ours, she is in fact at the present time a consultant gynecologist and oncologist at the Wits and Donnie Gordon Center, and she's speaking and presenting from Johannesburg. So I'm going to ask Trudy to share her slides. Chris, has Trudy joined us yet? I know she was here a minute ago. She just
I'm here.
Popped out. Okay, there you are. Thanks, Trudy.
I'm just going to share my screen.
Thank you very much.
Are we on it?
We're on and off.
Thanks, Peter. I'm not sure if I should thank you, but thank you for inviting me this evening to speak about the new contraceptive that is about to join us on the market. So I just really want to start with this because I find this quite profound. And this is the private practice figures of what is sold around the country in the last year. And if it's quite different compared to the government sector. So if you see in the private sector, the vast majority of contraceptives that are used are combined oral contraceptives. And that changes compared to the government sector where the injectable is the commonest. But what I want us to look at this is look at that massive amount of emergency contraception that we are using. So we are not actually providing a good enough service to reproductive women when 2.4 million doses of emergency contraceptives are being dispensed, which is a good thing. I mean, at least it's available to women. But I mean, I think this is a missed opportunity, and these women really should be counseled and perhaps started on some form of permanent contraception rather than utilizing emergency contraception.
Trudy, if I can just ask a question, yes. That first slide ago, the emergency contraception EC, that is available over the counter to women, is it?
It's available over the counter from pharmacies to women, yes.
And the combined oral contraceptive pill, that obviously
is not available over the counter in South Africa. It needs to be scripted.
Okay, thank you. But overseas it is. There's many millions of...
Overseas it is, yes. Yeah. Overseas it is, but it's not in our country.
Thank you.
So if we look at the evolution of the contraceptive, is that, I don't know if anybody realizes, but in the 60s, when contraceptives first became available, first of all, you had to ask your husband if you could go on a contraceptive. You had to get husband consent, which is really bizarre in today's day and age. But in the 70s, basically, we realized that oral contraceptives had a correlation with a VTE risk. And it was only in the 80s that biphasic and triphasic pills were introduced. And when we realized that these contraceptives actually reduced ovarian and endometrial carcinoma, And in fact, if you look at BRCA gene patients or patients who carry BRCA genes, we put them onto combined oral contraceptives because we recognize that it decreases your ovarian carcinoma risk. It was in the 1990s that the formulas started to introduce lower doses to try and decrease the estrogenic side effects. And it was in the 2000s that the extended use or the continuous use of combined oral contraceptives were introduced. We never got them in South Africa, but suffice to say that the placebos were developed for women by men because they thought we wanted a period. And in fact, you don't need to take the placebos. And then it was in 2010 that they introduced oral contraceptives that contain the natural estrogen, estradiol, and estradiol valerate. Prior to that, all the contraceptives that are on the market contain ethinyl estradiol. And there are two contraceptives now, Clara and Zoli, that contain estradiol, the natural estrogen that is found in your body.
Trudy, the problem with Clara is that, it's impossible virtually to have a period-free Clara because all the doses vary. And
Correct.
People ask me, how do you go on non-cyclical dosages for Clara? And the answer is you can't really, unless you're prepared to buy a hell of a lot of pill. No.
But the Clara from heavy menstrual bleeding perspective was the only pill that actually had a head-to-head trial with a levonorgestrel containing IUD with Mirena. And in fact, the heavy menstrual bleeding significantly decreases with Clara. But yes, it only has 2 placebos. The interesting thing about Clara is that it's quite a good pill to use in women with menstrual migraines because it only has 2 days of placebo. But I think what is important for us to recognize is that ethinyl estradiol, that's what's in Yaz, Yasmin, Nordet, Trifazole, all the other pills, is that it modifies liver function and it results in cardiovascular complications. So we know that it's a potent inducer of protein synthesis, and there's an increased VTE risk. It also causes activation of the RAS system and possibly has a link with hypertension, and it affects your lipids and your carbohydrates.
Sorry, what's the RAS system? RAS system. Yes. You said potentiates that. What is the RAS system?
So that's your renal angiotensin system. Yeah, which has a link from a hypertensive perspective.
Yeah.
So when you look at those ethinyl-based oral contraceptives and you looked at the risk of venous thrombosis, I don't know, for me, it's always quite fascinating that your maximum venous thrombosis risk is actually postpartum. And that, the risk of having a venous thrombosis is infinitely higher than women who are on oral contraceptives. But we often forget that. But remember, the levonorgestrel with the ethinyl estradiol combination had the lowest risk. But anybody with a thrombotic risk should not be put onto a combined oral contraceptive. We know that that's a no-no. It doesn't matter what kind of estrogen it contains, is that if you have a thrombotic risk, you cannot go onto a combined contraceptive. And that includes the patch. I find it quite astounding that lots of people still think that the contraceptive patch is the same as the hormone replacement therapy patch, and it is not. It is not, because it contains ethinyl estradiol, and it's the ethinyl estradiol that is a problem from a clotting perspective. So when we look at ethinyl estradiol, the higher the dose, the more clot risk there is. So if you're using, for instance, Overall contains 50 micrograms. It has a much higher clotting risk than, for instance, the 20 microgram pill. So the lower the dose, the lower the risk from a clotting perspective. The other common side effects of ethinyl estradiol is bloating, breast tenderness, and nausea. So, particularly bloating, if you combine
It seems Trudy lost connection for a moment.
Yeah. Chris, can you assist her in any way for the moment?
Unfortunately, it's a connectivity issue, so I cannot help her with that.
Oh, she's got connectivity issues. I'm just going to phone Trudy. I think she may have an unstable connection for the internet, Chris. I've just seen.
Yeah.
Does she know that she's lost connectivity, Chris, or don't you think so?
Yes, it should know. It should show her immediately.
Okay. I'm just going to give her a ring.
Can you hear me again? Sorry, I'm back.
Yes, I think we lost connectivity. Maybe
I went to my office so I could have better connectivity, and I apologize.
Was this a load shedding issue? Do you
but
think?
I'm back up and running.
Okay, thanks, Trudy. You were saying?
So I was
now we can
about the bloating with the gestodine. Did you get that?
Yes, we did.
Okay.
That's where we lost you.
All right, so I'm back on. So what they did to try and reduce the estrogenic side effects is they lowered the dose of the estrogen to the 20 microgram pills. And then what they did is now in the 2000s, they introduced the Zoli and the Clara. And the Zoli and the Clara, certainly from an estrogenic and a VTE, seems to have a better side effect profile. But the problem is the bleeding profile. I don't know if you have recognized that you get bleeding issues on the estradiol and the estradiol valerate pills. And that's related really to an unstable...
Well, the great thing about Clara is that
Yeah.
Sorry, Trudy. The great thing about Clara is that the women tend to bleed less, and that's a great advantage to many women. And also, of course, they can take it right through to the menopause.
Well, they can, and the same with Zoli. Look, the bleeding profile on Clara is perhaps a little more unstable compared to the Zoli, and the other thing is that you can get amenorrhea, and strangely enough, in a study that was actually came out of Cape Town University, is South African women like a period. They don't necessarily, they find it very disconcerting not to have a period.
Absolutely agree. And if you suggest that they go on something, they say, yes, but it's natural to have periods. And you and I know it's not nearly natural, and it's an inflammatory condition. Exactly. Hence the problem of endometriosis.
Yeah, absolutely. And so, but again, it's really for some women a problem if they don't have a period. And what's also interesting is if they don't have a period and you change them to another pill, they often remain amenorrheic. I don't know if you've noticed that.
Yeah.
So since then, what's happened now is they've introduced a new estrogen. It's called estetrol. It's E4. And this is what's in the new contraceptive. So the estrogen does seem to matter. So let's discuss why you have estrogen in a pill. If you think about contraception, the main contraceptive thing is the progestogen. So the progesterone gives you contraception, and they added the estrogen to give you a much more stable endometrium, to improve cycle control. It does have some effect on your follicular growth, but we also know that adding estrogen prevents some of the low estrogen symptoms. Like if you are on prolonged Depo-Provera or a Mirena, you can get vaginal dryness and dyspareunia, just the same as you do postpartum or in the menopause. So often women who are on Depo-Provera or the Mirena, you actually sometimes need to use vaginal estrogen in order to stop this dyspareunia and vaginal dryness. So estrogen does play a role in contraceptives. So the ethinyl estradiol, this is what it looks like. It's got a triple bond carbon CH bond, and they all have a similar structure to estradiol, but it's the ethinyl estradiol in the old-fashioned pills that predominate, and they don't get broken down in the liver. It gets metabolized in the liver to ethinyl estradiol sulfate, and it continues going round and round in the liver, and it affects cytochrome P450. And that's why many drugs that are metabolized in the liver, if you're on antibiotics, antifungals, etc., antivirals, the efficacy of the pill is less. And that's through the cytochrome P450 and its liver metabolism. And ethinyl estradiol does not get broken down into E1 or E2 at all. It basically remains and is very potent. Whereas estradiol actually gets broken down into estrone, a much weaker estrogen in your liver. It also uses the cytochrome P450. And from a liver perspective, if you are taking antibiotics, etc., it will affect the efficacy of both the estradiol pills and the ethinyl estradiol pills. But I want you to appreciate the difference between ethinyl estradiol and the natural estradiol pill. That's why ethinyl estradiol is not found in hormone replacement therapy, because it's way too potent. Whereas the estradiol pill is a much better pill in the later part of life, towards your menopause, like you said, Peter.
Yeah.
So what is different about E4? So it's a very interesting molecule. It was founded in 1965 in Stockholm, in Sweden. I unfortunately can't pronounce this gentleman's name. But it was first used as a biological marker of fetal well-being. And that's where its investigation stopped until recently. And estetrol has a much more prolonged half-life compared to estrone, estradiol, and estriol. So remember I showed you the estradiol gets broken down to estrone in the liver. So I always find it quite fascinating by these people who use the bioidentical hormones, because they mix the three hormones together, but in fact, all estradiol gets broken down into estrone and estriol. So it's pointless actually mixing those into the mix, but that's a discussion for another day. So estetrol, a very interesting molecule. So it is made in the human, but it's made by the fetal liver. So estradiol and estrone are made in the ovaries. E3 is predominant in the placenta, but estetrol or E4 is actually made in fetal liver. They don't extract this from fetuses. It's made synthetically in the lab, but it comes from, it's made predominantly by the fetal liver. And why it's interesting is that it is an end product. It does not get converted to estrone, estradiol, or estriol in the liver, and it is not affected by the liver enzyme cytochrome P450 at all. So it is not metabolized in the liver, and that makes it really attractive, particularly from a breakdown perspective, and possibly also from persons who are on medication that is broken down in the liver, like, for instance, persons that are on anti-epileptics, ARVs, etc. But it's not exclusive to that. The other thing that we know about it is if it's not broken down in the liver, it has less effect from a coagulation perspective and less effect from a carbohydrate metabolism, etc. So it's a different kind of estrogen. The risk for VTE may be modulated by the expression of the CYP enzymes involved in the hepatic metabolism of estrogen. And because this is an end product, we know that it probably has far less effect from a clotting perspective. But again, anybody with a thrombotic risk cannot be put on this drug and cannot be put on any estrogen-containing contraceptive. So I don't want you to walk away to think that you can put somebody who's got a protein S or protein C deficiency on this contraceptive. The answer is no, 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 no. But it probably will cause less VTE risk. The interesting thing about it is that E4 activates nuclear estrogen pathways, but it blocks membrane pathways. And for that purpose, it has minimal impact on liver metabolism. So when you look at its efficacy, it is neuroprotective in the brain. And that's important because we know that particularly perimenopausal women and menopausal women get brain fog. But estrogen is a happy drug in your brain. We know that it works on the uterus, so it gives good cycle control. We know that it prevents osteoporosis. And we know that from a vascular system, it probably causes less VTE. But even more important, it has minimal impact on breast, and it has minimal impact on malignant breast tissue proliferation, and it has minimal impact on the liver, and obviously it inhibits ovulation because that's what we want it to do. So it's anti-estrogenic in your breast and your liver, but it is positive on your bones, your brain, and your uterus, and probably better from a clotting perspective. You're all following so far?
Yeah, no, we're very keen to see where this is going in terms of the new formulation.
Overall, what they did is when they looked at this molecule, they combined it with different progestogens, and they ultimately settled on drospirenone. So drospirenone is what you find in Yaz and Yasmin. And in Yaz and Yasmin, they use 3 milligrams of drospirenone, and they use 14.2 milligrams of estetrol in the phase 3 trials. And they conducted 2 trials, one in the US and Canada and one in Europe and Russia. There are no African trials. But when we look at these trials, I think you'll see that they decided on using the drospirenone because it has anti-melanocorticoid effects. So it reduces bloating and fluid retention. And it therefore has probably a beneficial effect from a blood pressure perspective. We know drospirenone is anti-androgenic, so it improves acne. And we know that it is anti-estrogenic and has an anti-proliferative effect on the endometrium. So it doesn't cause hyperplasia, and hence the choice of drospirenone rather than levonorgestrel when they decided to make this pill. So in the US, they basically, they got women between the ages of 16 and 50. And of those women, 16 to 35, which is your reproductive woman or considered your reproductive group, they looked at that, and they also looked at the older women. But they looked at contraceptive efficacy, And what I think is also important is one of the few trials where they looked at body mass index, because we all know that in the US and Canada, that the BMI is elevated compared to elsewhere. And we also know now in South Africa, we have a big problem from an obesity perspective. The secondary outcomes was the bleeding patterns and obviously a safety analysis. The Russian group of women, they had slightly older, 18 to 50 years old. They also looked at method failure. They looked at BMI in these women, and they looked at bleeding patterns. So if you look at the body mass index, in the women 16 to 25, when they looked at them overall, 11% of their population was obese. And overall, 14.9%. Obviously, the older women were slightly porkier than the younger woman. They also looked at starters, so people who
Sorry, Trudy. I don't think we can use that term. Porkier is not a medical term.
Slightly BMI, higher BMI than the younger component.
It's a pejorative term.
Yes, you're right. You're absolutely right. And in terms of race, there were less Black women than there were, and the majority were white women in the group. They looked at the difference between what they call switchers. So that's somebody who basically went from one contraceptive to this contraceptive straight away. They looked at people who had never been on a contraceptive. And then they looked at women who stopped the contraceptive for over a month and then restarted the contraceptive. And that's also important. Whenever you consider changing contraception, you should switch straight away without a break, because as soon as you take a break on a contraceptive, you increase their thrombotic risk. So does it work? So when they looked at it overall, there were 31 pregnancies amongst the 26,000 cycles, 14 of which were user failure and 17 were method failure. So overall, the Pearl index was 1.52, which is very competitive and comparative to the Pearl index of all pills overall. And when you look at method failure, in fact, the contraceptive efficacy was 99%. So we know that it works. And we know that the Pearl index is similar to all other oral contraceptives. But what about the bleeding profile? Because we spoke about that right at the beginning, that South African women like to bleed, and also that if you have irregular bleeding, it becomes a problem and your dropout rate is much higher. The problem with bleeding profiles when you read trials is that it differs in many in the literature. And so if we talk about bleeding, we talk about evidence of blood loss that requires the use of sanitary protection, whereas spotting is minimal blood loss that does not require the use of sanitary protection. They looked at episodes of bleeding. They looked at scheduled versus unscheduled. So scheduled and withdrawal bleeding is what you get in terms of your placebo. So that is a scheduled bleed, whereas an unscheduled bleed is something that occurs on active hormones. And then obviously amenorrhea is if you don't get a period at all. So when I talk about bleeding, if I'm talking about spotting, it means it didn't need any sanitary protection, and whether it's scheduled or unscheduled. So overall, scheduled bleeding or spotting occurred in 87 to 90% of participants. So the vast majority have a period of sorts. They bleed. And the average person, it lasts between 4 to 5 days. So your amenorrhea rate is far less than the estradiol containing pills, which I think is quite important for us. That most of the unscheduled bleeding was spotting. So, in other words, most of it did not require any form of sanitary protection. And I think that for me was quite reassuring in terms of the unscheduled bleeding. So overall, the discontinuation rate in the phase 3 studies in the pooled analysis was only 3%, which I think is quite good. And then what about the clotting? So it's difficult, obviously. You need large trials to actually look for a clot. So you need to look at surrogate markers. And they looked at activated C protein or activated protein C resistance as a surrogate marker for VTE. So your activated C is a physiological anticoagulant. So if you are resistant, it means you have a major risk for a clot. And so they looked at your APC resistance as a biological predictive marker of VTE. And that is what is used in most contraceptive trials. And what they found is that the higher your estrogen, the higher your APC resistance is, and the higher your risk is from a VTE perspective. So when they looked overall, so this is now comparing ethinyl estradiol with drospirenone, in other words, Yaz, compared to ethinyl estradiol with levonorgestrel, so that would be Nordet, and they compared that to the new estetrol containing pill with your drospirenone. And your APC is significantly less, because remember, there was this big thing about Yaz causing DVTs, etc. So the combination of the estetrol with the drospirenone has a much lower APC resistance, and therefore we presume will have a much lower thrombotic risk than either the levonorgestrel containing pills or the drospirenone containing pills. And I think that's quite reassuring.
Trudy, can I just quickly, there's a person that's been asking this question, and just to for you to answer it and to have a glass of water. She says, or he says, women accept that the injectable, that's the Depo-Provera, and the Mirena cause amenorrhea. Do you have any idea why there's a belief that it's necessary to bleed on the pill? And then, you know, from that is, why can't they bleed every tricycling every 3rd or 4th month? Do you have any idea why?
You can absolutely tricycle every 3rd or 4th month. But remember, when you have a Depo-Provera injection, you know that injection is in and it's working. The same as when you have your Mirena or your Kylina, you know it's in and you believe it to be working all the time. Whereas the oral contraceptive, you're like, oh my God, did I have diarrhea? Did I vomit? Did I take antibiotics? Did I forget a pill? It's user compliance. And what's quite interesting, I don't know, Peter, if you know, that the average adolescent forgets about 2.5 pills per cycle.
Yeah, it's like me trying to take antibiotics or antivirals. Yeah, you remember sometimes.
I was useless at giving my children their medication, you know? So I think that's why there's a lot more security in that I have amenorrhea on my pill or my injectable, because I didn't have to give it to myself.
Yeah. Okay,
and it's long acting. It's a lock.
It's a very good point there. You know that it's working with your period,
Exactly. As compared to the pill, you know, then you're wondering, you're second guessing yourself all the time. There is no reason to have a period whatsoever. If you read Guillain-Barré's book, he will say you can take continuous combined contraception until you have a breakthrough bleed Then you take the 4 placebos or the 7 placebos according to what that pill normally is. Did you know that?
Yeah.
And in
Yeah, I
fact,
do. I'm the first person to say
in Europe, there are no placebos.
Yeah.
At all. Yeah.
I think the but as you say, it's
yeah. Can you hear me?
No, we're listening.
Okay, good.
I'm just waiting for some person to say we're talking.
So what's quite interesting as well, like I said to you, the BMI is high in the US Canadian cohort. And even in that high BMI group, they did not have an increased incidence of DVTs.
Yeah.
And so, you know, the BMI was greater than 30 in 26% of that cohort, and their VTE risk was not increased. So even in somebody with a high BMI, the estetrol pill is compatible and you can use it.
You talking, but you mustn't interrupt us so much.
Can you hear me?
I can hear you.
Good.
My wife says I must stop. Elrene says I must stop interrupting you so much. I'm sorry, I won't interrupt you so much.
No, you're most welcome to interrupt me. So what about the metabolic and the endocrine parameters? So they also looked overall in all the studies, they looked over 3 and 13 cycles, whether there was a change in the cholesterol from baseline, whether there was a change in the HDLs, whether there was a change in the LDLs or the triglycerides, and there was no change overall in the lipid profile. So for me, that's also an important factor to take into consideration, because the ethinyl estradiol containing drugs definitely have an adverse effect from a lipid profile in women who have an underlying hypercholesterolemia. The other thing that they looked at was the impact on glucose. So in women, compared to baseline over 13 cycles, there was no difference in their glucose and there was no difference in their HbA1c. And so from that perspective, also no effect from a metabolic perspective. So overall well-being and quality of life, if you look at the adverse or the pooled data in the studies, the bleeding complaints, they were the maximum at 9.5%, but nevertheless, compliance remained steady. There was very little weight increase, because now all the patients always ask about weight. And, you know, my comment on weight is that it's not really, that little pill doesn't have so many calories in it. And that, you know, it is unfortunately what we eat from a weight perspective. So the bleeding complaints, the breast tenderness, the acne, the mood disturbance, the dysmenorrhea, they gradually got less and decreased by cycle 10 to 13. And that makes absolute sense, because that's why you use drospirenone, is to decrease your acne, and it doesn't go away in one cycle. You know, you have to tell patients that only after 3 cycles do you see a difference from a dysmenorrhea and an acne perspective. So they looked at weight. So compared to baseline and at 13, there was no change in weight. And I think that's important. You're not going to lose weight on it, but you're not going to gain weight on it. And I think that's also important when we speak to patients about this new pill. Acne decreased the longer you took it, and that makes absolute sense. So there were very few cases of severe acne, and your acne improved with time. As did dysmenorrhea. And I mean, that's one of the reasons often we put young adolescents on the oral contraceptive, is to decrease their pain. and dysmenorrhea was significantly less by cycle 4 compared to when we started the pill. So I think we must bear this in mind. It's a new contraceptive to us. I can't wait for them to use E4 in a hormone replacement therapy because of the breast protection. But for now, we know that this E4 drospirenone pill is a different concept in terms of its effect on the liver and its effect on the breast. And if you all want to know what its name is going to be Drovelis. Don't ask me why, but its name is Drovelis. So naming something is quite interesting, is that you have to apply for a name. It cannot be a girl's name anymore. So Yas and Yasmin days are over. You're not allowed to use a girl's name at all. And the name is not dictated necessarily by whoever the company or whatever is. But this drug's name will be called Drovelis. And you can ask me any questions.
Trudy, that was a wonderful, wonderful talk. And thank you very much. Do you have any idea when Drovelis, you kept the best last, Drovelis, where does this name come from? I mean, I could think of many other more attractive names that, Drovelis reminds me of my grandmother's auntie, and she was called Aunt Drovelis. Isn't there a better word? Where do they pluck these names out of? Do you have any idea?
They applied for a few names, and this was the name they were told they can use, if I'm not mistaken, but I'd have to ask the company exactly where the Drovelis name came from. But like I said, you cannot use a girl's name at all anymore.
And a boy's name? Sounds like a boy's name.
I don't know.
Trudy, which, if I may ask, I know they're not sponsoring it, so we don't have any problems whatsoever with advertising.
So
who is going to be which?
So it's been brought to South Africa by Adcock Ingram.
Okay, thank you very much. Yes. And when is it going to be released? Do you know?
It will be available from July.
Oh, next month. Okay, that's great. Yeah, I've got a lot of people say that it's a shocking name, but I mean, these names are funny. Look at Clara. When it first came out, really, nobody could spell it. So it is what it is. And you've had a wonderful, it's a wonderful, wonderful talk you've given. We've had many hundreds of people, and it shows you what a draw card you are and what an interesting topic this is. So it's something to look forward to. Another question over here, you said you can't wait for it to be in hormonal therapy compositions.
I think it is in Europe now. I think it is available in Europe in an HRT, yeah. But not with us at the moment, as far as I know.
You've given us a historical perspective. It first became available, or it first became formulated and synthesized in the 60s. Why has it taken so long to become available as a pill?
It's difficult to say. It takes a lot of money to invest in a drug because, it has to go through phase 1, safety, etc. I think, it was predominantly looked at from a fetal well-being perspective, and then was moved into a contraceptive. It's been around in Europe for a while.
Okay. Oscar Shemangi sends his regards and says it's a wonderful talk. And we fully agree with him. It's been beautiful. And Anonymous says, can it be used as a HRT? And you say, yes, it is going to be available. And it is
not, this pill is not an HRT. This is a contraceptive pill. Yes,
I think Anonymous means can E4 be used as an HRT, not Drovelis. Obviously, Drovelis is a pill, combined oral contraceptive pill, not an HRT, but can we use it will be available. Did you say it is available in Europe as a hormonal therapy component?
I think they're working on it, but I think they're definitely working on it. But I don't want you to go away thinking this is an HRT, because drospirenone cannot be used as a progestogen in HRT. This dose is way too high. It's the same as, Yeah, I mean, Drovelis, but it's the same as I get some women who are on Zoli when they're like 57, 58 years old. I mean, no, it needs to be stopped. You cannot
Yeah.
be on an oral contraceptive, even an estradiol containing oral contraceptive, into your late 50s because of its thrombotic effect.
At what stage should you stop Clara then? At
So,
what age?
So the how you should stop a combined oral contraceptive is at the age of 51. And then you should be measuring the FSH. I mean, whether the measurement of FSH is accurate from a menopausal perspective, but I always tell patients at 51, you stop your pill, we measure your FSH on day 4, and then we must remeasure it again 6 weeks later to see whether you are truly menopausal. I mean, obviously, there will be a small group of women who will go on to menstruate much longer on a regular basis, and you have to tell them to use alternative forms of contraception.
Yeah. Okay, Trudy, it's been wonderful. And I look forward to hearing you at some stage on our platform once again. You're a great draw card. We got all these hundreds of people logged on, and it attests, in fact, to your popularity. I also look forward to seeing you and maybe having a beer with you at FIGO in Cape Town in October, the beginning of October.
So I will definitely be at FIGO. I'm presenting stuff at FIGO, but I would, encourage people to be at FIGO. I know it's very expensive, but if you can form a group, and then if you're a SASOC member, you also get a discount, by the way. You do.
There are plenty of opportunities for discounts available. If you're a SASOC person, if you get your cohort of your colleagues together, it's hugely. And of course, it's you just have to come down to Cape Town. Once you're here, you can stay with friends, you can stay with family, you can stay with anybody you like. And it's an attractive option to come down and have a jolly good holiday. It's a nice time of the year. Thank you very much indeed for that endorsement, Trudy.
Pleasure.
Okay, now we're going to have to thank Chris. It's been wonderful having Chris's help as well. I'm sorry that you broke up in the middle. It's probably a bit of load shedding or unstable platform. But Trudy, a very, very warm welcome to you. As always, thank you so much. It's been a lovely talk. People have loved it, and we've had a very good turnout. Until next time, all the very best to you, and God bless. Safe home. I know you came out of home to your office to get a better connection, but all the very best to you and safe home. Thank you, Trudy.
Pleasure. Bye-bye.
Bye-bye.